languages you're gonna be translating so I can assign you the rights. Thank you.
Hi, can you hear me?
Yes, I can hear you.
George, can you hear me?
Yes.
Yes, can you please assign me?
Are you interpretation?
Yes, yes, interpreter, Portuguese interpreter.
Okay, English and Portuguese or
English and Portuguese, we do both.
okay. So George, and just try to rename yourself so you can put like the initials of the languages in your name at the end so we know
Where do I go to rename
uh
myself? Yeah,
next
where do I
yeah,
go?
next to your name, there's the little three dots. You should be able to just click rename and change your name. Um Anyone else online part of the interpretation team? I see Maya and I see Suzette.
It's only Suzette and George that are doing Portuguese. Then
Suzette for
Jackson
Portuguese.
will,
Okay.
yes.
Okay, so there we go. So I have Bobik and Jax for French and English, and George and Suzette for Portuguese and English. I'm gonna see if I can start it now. Just give me a second because this thing is glitching as usual. Okay. Okay, all four of you should have the rights now. We can start by testing the English channel. Loud and clear. Yes, loud and clear. Yes, English channel. Be there in a second. Hi, Bobby. I can hear you. So, Seth, if you can come to the English channel for a second, just to make sure I can hear you. Good. Okay, good. Let's go to French first. Yes. Yes, I can hear you. There's a bit of echo and background noise, but that's probably just your microphone. Let's go to Portuguese. Okay. Yes, I can hear you both. Suzette, can you talk again? Just, uh, okay. It's not 100% clear. Your microphone might not be the best right now, but I can hear you. Yes. Okay, cool. Good. Okay. Now, as per the request from the AV team, just try to rename. So at the end of your name, you have the initials, just like we put on the chat, just like this. Thank you.
Hello. Hi.
Good evening. I know we are all excited to be greeting each other, but I will call us to order. I want to acknowledge those of us who are online. We don't have a very big room. I think we started off a little bit. Is there any way we can? Okay. We started off a little bit as a small closed meeting, but I think by public demand, we are having an open meeting, and I really want to thank. Yeah. Let me start with protocols. I think as a government officer, once in my life, I never lose that. So say UNAIDS, the Deputy Executive Director, Director Generals, the Ministry of Health officials who are here, partners, stakeholders, our funders and support, the Gates Foundation, the Global Fund, communities of people living with HIV, other communities, friends, colleagues, and all of us who are online. Good afternoon. Thank you very much. You may, at any one time, walk and get coffee quietly. Oh, thank you. Thank you very much. And it is now my pleasure. Okay. I think we have switched off all microphones. No. Okay. I will try, and hope that I can see they are trying to work on it. So I think we are going to be fine. So just hold the mic. It is now my pleasure to invite the moderator and our host to this meeting, Dr. Prosper Kambong, to come and start off the meeting for us.
Thank you very much, Dr. Nduku. And I would just stand on the protocol established by Dr. Nduku, but let me particularly recognize the UN leadership here, especially Dr. Angelique Ekrika and the team who are here. The team who are here. I hope I got it right. Yes. I want to recognize fellow Director Generals from various countries who are here with us. And then there are a few people that we also need to recognize. Those online, I recognize you. And then the program manager for the National AIDS
Manager du programme, Dr. Tego. Je voudrais également vous reconnaître son adjoint, Dr.
And there is Deputy Dr. Shinyo. There are some directors from the Ghana AIDS Commission who are
Dr.
also here.
Shinha, temos aqui alguns diretores da comissão aqui do Ghana. Também permitam-me aqui reconhecer o Dr. Pile do Gates Foundation, Fundação Gates, por favor. Levanta, muito bem-vindo, como indicado aqui pelo Dr. Nduku. Temos aqui a UNAIDS e a parceria global.
Dr. Prosper Kambong, Director General of the Ghana AIDS Commission. And on behalf of all my president and all Ghanaians, want to welcome you to Ghana. The best place you should be at this particular time. The country with the best jollof. Because those of us who were at the presidency to attend to the OFLAT program, the program was cut short because of the smell of the jollof that was coming from the other side of the hall. It is my profound pleasure to welcome you to this meeting. It has been in the offing for some time through many discussions on our platform, and many suggestions have come on. But this is the time that we should take the real discussion to the table and see how we can champion our way forward. I would say that until last year, Ghana was a co-convener of this forum, the steering committee, and I'm honored to be guiding this discussion today. We begin with the opening remarks from Dr. Musukuchuane Kebi, if I got that right. Yes. So let's welcome Dr. Kebi for his opening remarks so that we can kickstart this program. Thank you, Doctor.
Thank you very much, Dr. Prosper. I will not go through the list of the protocols. I will ride on the protocols that have already been established by Dr. Prosper. And as you heard, my name is Kebi Musovotoni. I'm serving as the Director General of the National HIV/AIDS STI/TB Council of Zambia. At the same time, I'm Vice Chair for the HIV Leadership Forum. The forum is a community of practice of Director Generals of Africa, Asia, Latin America. It is the only country-led and government global HIV platform in the response. It's my great pleasure to welcome all of you to this important session, and I'm delighted to see representatives of ministries of health across different countries, Director Generals of AIDS commissions, the global and country HIV stakeholders, and the community partners gathered here today. Our focus this evening is to surface country-driven priorities for a coherent and effective global response. As many of you know, the HIV prevention landscape has evolved significantly. We have seen remarkable biomedical advances that have expanded prevention choices, while countries are increasingly taking on greater stewardship of their national responses. Now, while countries are organizing to strengthen their HIV prevention, there are ongoing global processes that intersect with country action. This session today is intended for us to reflect and reimagine an HIV prevention program that countries can steward, finance, monitor, and implement sustainably. We also recognize that while countries, including governments and other stakeholders, are rebuilding HIV prevention, there are ongoing global processes by UNAIDS GPC, by the Global Fund, and by the Gates Foundation. And this session will feed into these processes. Thank you all for being here and for your ongoing commitment to advancing HIV prevention. I look forward to a productive and engaging discussion. Thank you.
Thank you very much, Dr. Kirby, for this wonderful opening remarks. And the key issue key issues are that there are new advances in prevention methods, and in the landscape of declining funding to the HIV responses, it is time for us to have a deeper thinking into how we can get very effective preventive measures to our national responses. At this moment, let me invite Dr. Anjali Krishika for her opening remarks on this issue. Thank you,
Dr. Prosper. And it's really great to be with you all today. My name is Anjali Achreker, and I am really privileged to be at UNAIDS working as part of the Global Prevention Coalition with all of you. We really are at an extraordinary, important inflection point in the prevention landscape. I won't spend time talking about the crisis that we're in, other than to say that while we have new innovations, like Dr. Kebi just mentioned, and incredible opportunities to close gaps, we are seeing an extraordinary lack of funding, lack of commitment, while gaps persist for prevention. This is the opportunity for us to come together, to think differently, to act differently, to really make sure that we are prioritizing prevention, both comprehensive preventions with the new innovations that exist, but also all the other modalities that exist. Condoms, pre-exposure prophylaxis orally, long-actings, but also treatment as prevention. We also need to make sure that we're prioritizing different ways of working, how community systems need to be a part of prevention. How do we bring prevention services in a more differentiated way to better meet people's needs? We still have 1.3 million new infections every year, and we anticipate that that will continue to increase if we do not accelerate our efforts right now to close those gaps. With this financial crisis that we're seeing, we're particularly concerned about the fact that countries are having to make decisions between what they prioritize and what they don't. We're seeing priorities focused on essential life-saving treatment services, and what's collapsing are prevention services. Now, we need to make sure that prevention services and treatment services continue, but by reimagining how prevention can be delivered, by reimagining how we can better serve people where they are, there are efficiencies that can be gained. And so we need to prioritize both prevention and treatment. So I am very much looking forward to this conversation, to the leadership that exists at the country and community levels, to continue to find ways that we can work together, collaborate together to use evidence and data and community systems and people-centered services, new technologies, not only the innovations that exist in the medical field, but how do we use new technologies in AI, in service delivery, to better serve people where they are. So I'm just very excited about this conversation that will happen here, and most excited about the action that will take place after we leave this room. So thanks very much. Looking forward to the dialogue today. Thank you.
Thank you, Dr. Anjali Ashika. You couldn't have said it better. The ball is now caught. The issue is prioritization of prevention with new technologies and other existing technologies that we know. The prioritization should go alongside treatment as well as prevention, so that both should go hand in hand. And who are better to do that than we, the leaders of the HIV responses in our various countries? The ball is now in the court of we, the leaders, to take up this call and in this discussion so that we can get a way forward. At this moment, it's unfortunate the health minister is not here with us, but he has an able representative who would make some few remarks on behalf of the Minister of Health of Ghana. I call on Dr. Emmanuel Teview, the Program Manager of the National AIDS Control Program for Ghana, to make some few remarks on behalf of the Health Minister.
Thank you very much, my Director General. These are very huge shoes for me to step in. Ideally, I'm sure Director General should have been doing this, but since he's chairing this session, he has asked me to do this on the minister's behalf and on his behalf. Yeah, so I think as a country, Ghana is not an island. We are also, experiencing the effects of the financial landscape. But I think as a country, we are fortunate to have quite a resilient and robust health system that has managed to absorb some of the shocks of the landscape financially. And one of the things that we have is that we have a very structured health system up to the community level that is already existing, and already we are delivering PrEP services, oral PrEP, in addition to the other available tools like condom, behavior change, and all that. Now we are also positioning ourselves as a country to embrace the new tools that are available to us in terms of lenacapavir. And I must add that already in our guidelines, we have oral PrEP and then injectable PrEP as part of our guidelines. So we are in the process of updating our guidelines to specifically include PrEP. And we have a very well-respected and reliable regulatory body, the Food and Drugs Authority, who are our very close collaborators. And they will also help us in terms of observing or monitoring adverse events in case we finally decide to adopt the lenacapavir. One other key area that we have, which is an opportunity for us, is the commitment at the highest level in terms of leadership and political commitment. When this issue of financial stop order came, our president gave clear instructions to the Ministry of Finance to step in to be able to close the gap. Following that, he demonstrated leadership again by organizing the Health Sovereignty Conference in Ghana and also in Onga. So that is clear demonstration of political leadership to support our response, particularly in the area of prevention. In addition to that, they are also supporting in the procurement of commodities like condoms for the country's response. And that is something that is also very ongoing. There are other initiatives that the government has also taken in the area of looking at how to sustainably finance chronic diseases, giving opportunity for HIV to be part, like uncapping the National Health Insurance levy to give more fiscal space to take care of this, and also looking at primary healthcare funding up to the primary healthcare level. And so these are some initiatives that are very good. And also we have a very good human resource at all levels who are, trained, though it will not be adequate, but at least we have some who are trained, who are also ready to help in rolling out these interventions. So I think that where we are not doing so well, which we acknowledge, is the awareness creation, the noise about prevention and all that, particularly targeting the youth who are we are now seeing an increasing rise of infections among them. And I think that we're also taking steps in that respect to be able to curb that. So as a country, we welcome you and we are doing our part in the global response. And we hope that together and collectively, we can win and beat HIV/AIDS in Ghana. Thank you very much.
Thank you, Dr. Tevio, Program Manager. Please, those online, if you are not hearing us well, kindly let the technical people know so that we can adjust appropriately. Thank you very much, Dr. Tevio, for giving us an insight to what is happening in Ghana, admitting that Ghana is on an island and can only learn from other countries and working together with other countries to get our prevention methodologies right. At this moment, I would want to hand over to Dr. Nduku to continue with the rest of the program. Thank you very much for your cooperation.
Could we please give Dr. Akambong like a real clap? And then the table that is not clapping, you will all come and dance over here. So let's do this once again. Let's give him a clap. Thank you very much. My name is Dr. Nduku Kilonzo. I am the co-chair of the HIV Prevention Coalition and Global Prevention Coalition. And while I am here, it is important to acknowledge my co-chair, Mitchell Warren, who is with us online virtually. I am also supporting the HIV Leadership Forum. The next session is really going to be our conversation, a discussion. This is the session where we get into the weeds of HIV prevention, understanding that we have a changing landscape. We have challenges not only of financing, but of
systems and programs that have been compromised significantly when it comes to HIV prevention. Recognizing that as we think about how we move forward, we have to think about what prevention, what integration for HIV prevention looks like, because it is much easier for HIV treatment where services are provided and availed at facilities, and prevention often is about making sure that people who are well have access and are able to access the choices of products that they need when they need them to ensure that their risk of HIV is mitigated, of HIV acquisition is mitigated. So the next, we are going to have 2 presentations. And because the chair of the session has given me a program ahead of time, this is very rare. I will make sure that we stay ahead of time. So I will ask the 2 presenters whom we are going to be hearing today from to be concise, and you have 10 minutes. And when you see me standing to walk near you, ... So I think at this point, it is my pleasure to invite Dr. Fode from UNAIDS, who is also supporting the GPC, to give us a vision of what prevention in the new architecture in the future could look like. I just want to note that you have documents that are in hard copy, Prevention 2030. Those are drafts. I will pause there because I'm sure you'll say the less. Over to you.
Thank you all. I don't know, colleagues, could I have the presentation, please? Ah, that's not the mine. The other one is. So, good afternoon, good evening, probably good, maybe good morning, even online. It's a pleasure to be in front of you. Also, a bit of stress situation to present to you. And I wanted to, before starting, to insist on what Dr. Duku said. This is a draft that have been developed within the working group of the Secretariat of the GPC, with the support, obviously, of the 2 co-chair, Duku and Dr. Michel, but is really a draft. So it's a starting point, is a co-creation, for a co-creation, I think, and now is a time for you and then to say how you will take that forward, how you will adapt it on the current situation and the country needs the best you can. Next. We're just starting by some data that was coming out of your UN Spectrum and some projection for our partner, Avenir Health. And then it shows very clearly that, you know, there is 3 scenarios. We have choice to make. There is the one that is we keep the treatment target achieved, and we are not that far from that. We are far, but we are on a good path. And then we maintain a sort of constant prevention, and we know that it's very difficult. We are more potentially on constant treatment and a reduced prevention of it. That is the current situation there. And then you can see that. And then that is the ideal is in green. And then basically say that if we don't sustain and accelerate primary prevention, we won't be there. I think it's important to have the scenarios here on which we are in front of. Next. So that was to illustrate and celebrate, you know, at least we are not there, but there is proud to see the level of reduction of the new infection regarding specifically Africa, both in ICASA and WCA. And by the way, WCA was seen as lagging behind for so many years. Great to say that that is equal. But you can also see that we are far from the 2025 target, not even talking about 2030 targets. Next. So in front of that, we all agree we need a bold vision. We need, some people say, reinventing, reimagining. There is all type of them behind it. We need to have an effective prevention, action, and intention at country level. That is what is this is about. Next. But we also know that we are Duku said it, the opening said it, that reality of funding crisis. But each funding crisis could also be an opportunity that we can seize when we can to do more, best, more the significant transformation we need. And then basically the second sentence is the most important, that the country to really own and take leads of their response with the best they can to have the most efficient program to optimally use the resources. Next. I just want, this is a complicated slide to say there is a huge process to discuss. Many of you was engaged on that to discuss the targets of the prevention that was central to the new global AIDS strategy, which has been launched very recently and then will be also presented to the political declaration in June 2026. Is just to say that that is a serious, that work has been done by the expert to have the prevention target. Next. That is now something which is just to illustrate. If we want to have, with the projection and the modeling, if we want to have 90% reduction of the new infection, which need we have 19 people in use of the prevention option and 90% of people with efficient treatment with the virus suppressed. So if you go through there, you will say that 40 million being on people living on treatment, we know that. 20 million using PrEP. But we discussed it even this morning. It's not enough to discuss of PrEP or to see that as the only way or only strategy. There is much more strategy that work, but we need to know what slogan we will take to bring all of that together, you know. But concretely it means 67 million adolescent girls, young women and men, but young boys to be reached, 36 million of key population, and then if you translate it with 6 billion of condom, you know, with high level in Africa, and then 7 million people who are injecting drug having access to harm reduction, you know. So the interest of that is you next step. We can then work out, you know, by country and even by district. That is an example of what country. If we reach 1.1 million of people under living with HIV on treatment, 2,000 using PrEP option, 35 million condom, 8,000 people who are injecting drug, then we'll reach the target and we can decline that at the district level, you know? So that is the way, I mean, there's a potential tool to use. Next. What is suggested here by the GPC is that we have a fundamental shift of the framing of prevention. And I would say that was maybe some of the key here is a person-centered approach versus to intervention-centered, is to go to a long-term option rather than limited daily option, is to have numeral annual target by country, which is very important because it will help monitor and follow and correct the program if needed. It's one national prevention program, which is about coordination, efficiency, self-care model rather than mostly provided initiative model, and finally, share the responsibility. So that is some pillar proposed in terms of vision for you to see if that could be fit on what the new framework could be. Next, please. So very complicated to see that if the person-centered prevention framework is like not everything to everyone, we have to choose between, you know, this sort of matrix. When you have, one is to take in consideration the context where we are or the person we are, you know, which is more about how do you sensitize, communicate with people around behaviors. You have to have a systemic approach with, you know, the needed platform of prevention you have. And I won't go into detail. Then important is not to have offer and platform, you have to use it like condom, ARV, clean needle, etc. And then you have to take that in the context of the structural barriers. It's insisting about stigma-free, the legal environment are probably the supportive and social gender norms. So that is the matrix all of that working under the multi-sectorial leadership, and you are the multi-sectorial leadership. Next. No. I will go through that, is an illustration that we can go next. Same here. Okay, it's just to say some example of table of that. Next, I will try to get. So basically we try, but as we discussed, the 5P to be new, and the 5P is to have the right people at the right place with the right package, using the best platform and tool at the best price. So that is a memo technique that could be discussed, but I will put it there, and you have an illustration of that. Next. So potential that to be discussed, timeline, but it has to be defined with you all, with all of us to see, which will be here the timeline. You will find it also in the document there, is to, in any case, the needs estimate will be done and revised on April 2026, that's for sure. And then we can then go to the sequences if the three first we keep the timeline. So that, again, a suggestion for us to work on today and beyond today. And I will say next. And we will finish by saying, but it's obvious, that primary prevention is indispensable to achieve the 2030 target. It will require a strong multi-sectorial leadership or it won't happen. And that's why the NAC forum, the NAC that you are so critical and important, specifically on prevention. It will need to add to reach and to consider community and society on it. Will new framework, and that new framework again system has to be country-led. It really has to be country-led, So that the new vision of the GPC has to, should I say, to give the, not necessarily give the power, but give the full space, the full direction and leadership to the country to define what are your needs, and partner has to come as potential support, no more, about your needs. And based on new granular data and estimate, and that is the final, I will find out about that. So this is a proposal that we have developed co-developed with GPC Secretariat. Again, it's a proposal, it's a starting point, it's not the end. Based on that, we can take 1% or 90%, is depend on the way we organize the work and the way you're saying. Thank you.
I don't do very well on soft claps, right? So thank you very much. And I think the reason why we needed to hear this is to help with the thinking, so that all of you are starting to contribute to the thinking about what prevention is going to look like in a different world. The world we came from, we had the prevention global roadmap, and now we are saying we need to think differently in the different circumstances. In addition to having had the global prevention framework, there's also other work going on at the global level, and the Gates Foundation has been taking time to review its HIV prevention approach and support specifically to HIV prevention and the operating global HIV prevention ecosystem. And this has been important because it is informed by the fact that there are changes, by the fact that countries need to be doing better, countries need to be doing differently, especially as they take on leadership. And therefore, that behoves the foundation also to think about its investments in ways that support what countries are doing, in ways that will help sustainability, in ways that will facilitate countries' availability to introduce not only products, but also interventions that are sustainable and long-lasting. And so Wanjiru will be presenting to us some initial findings from the work that has been done to try and inform what the foundation should be looking at in terms of its prevention interventions. Dr. Wanjiru Mukoma, welcome.
Thank you. I think I'm going to stand here. Sorry for standing a bit behind because I need to see the screen. So good evening. I will present very high-level findings of conversations that we've been having with very many of you in this room. and we will try and summarize what you said. So the next slide, Nduku has already spoken about the context. So from October to this month, we have been conducting interviews. We had some online self-administered questionnaires. We conducted a desk review, and we spoke to many of you, and we tried to conduct a thematic analysis of what you all told us. So in these few slides, next slide, I will focus on these 4 themes: the prevention landscape, which we all know, the prevention priorities that came out of the informant interviews and the questionnaires that some of you completed. We will talk about the success as was defined by many of the stakeholders, and then we will touch on prevention coordination for the future response. So when we analyzed the data, there were some critical tensions that emerged around the prevention landscape. And one of those is the lenacapavir versus combination prevention. And many stakeholders felt very strongly that the narrative of the magic bullet is undermining comprehensive prevention approaches. The second area of tension was condoms. It's already been said, zero donor funding dedicated to condoms, and yet all the country plans, strategic documents that we reviewed prioritize condoms 100%. The third area that emerged is sustainability of community organizations. I don't need to say much about that. I think some are here. We know what's happened to our community organizations, the shifts in funding. The fourth area is donor vis-a-vis country alignment and the disconnect that is existent thereof. Whereas donor priorities are product focused, countries are very much focused on the combination prevention needs. Next slide, please. And this is a quote from one of the respondents, that there's a follow the money dynamic, which countries tend to follow donor priorities due to funding dependencies. Yeah. The second thematic area was success. We asked, how do you define success in prevention? And overall, there was consensus that it's decreasing incidence and reducing new infections, and this will be achieved if we implement combination prevention. And the most commonly mentioned interventions were providing access to the PrEP options that we have and the ones that will come in the future, condoms and lubes, VMMC, U=U, STI services, and maintaining the focus on key populations and AGYW. Country leadership emerged very strongly. Countries saying that they need to take more leadership and have domestic ownership for the prevention response. A focus on reduced stigma and discrimination, ensuring that structural barriers, especially barriers to access for key populations and priority populations, is an essential component of the response moving forward. Innovations in service delivery and integration. This was said quite by almost all stakeholders that HIV has to be integrated. HIV prevention has to be integrated. There's no other way moving forward. A critical issue also that came up a lot was the balance of innovations, being especially the new PrEP products with proven tools that we already have. And there was really strong pushback against the exclusive focus on LEN. Next. Yeah, and that's another quote that emerged, that focusing exclusively on LEN will come to bite us. But whereas there was this convergence in general on the focus or the prevention success, there was also mentions of different pathways to achieve this success. For example, a lot of the donors focus on transition, efficiency, strategic outcomes, and shorter term visions compared to countries which focus on operational issues, service delivery, and have much longer term visions. Next. On HIV prevention priorities, in green are the areas where there was or the different shades of green don't mean anything, but it's just the areas where there was general consensus across stakeholders, and no need to repeat the issue around condoms was considered an area of divergence between countries and donor investments, whereas the focus on PrEP, while considered high priority, the exclusive focus on long-acting PrEP was seen as one of the demonstrative aspects of where countries are following the money, and it's not really the highest priority for them. Next. So imagine from that, we have some questions that I think will also inform part of the discussions we are having today, because what we wanted to do is just present the high level findings, preliminary findings, to entice the discussions that we are going to have today to enrich this. What are the essentials of combination prevention? It came up a lot. What must we continue to do? What must we stop doing? How can we simplify and reduce costs of delivery? And here we're not just talking delivery of products, but also the cost of delivery of programs. How will countries address the condom crisis? It's prioritized 100% and there's no donor money. So countries need to think about how they prioritize that. And this was one question that came up. Is VMMC dead? Should it continue, and how should it continue? And how can we leverage the LEN momentum to have a greater prevention impact beyond just LEN as a product itself? In terms of evidence prioritization, what data should countries leverage in order to prioritize prevention? Because we know what's happening to our data platforms for prevention. And one big question that this emerged as an important thematic focus going forward, integration of HIV, but what is it? What are its essentials? Where and how should this integration be delivered to achieve impact for prevention? Next slide. Another area we looked at is prevention mechanisms. We are familiar with the current mechanisms that are coordinating prevention. Collectively, these mechanisms have really made progress in terms of policy and strategic alignments, such as target setting for global prevention and for country programs. They have created opportunities for convening and coordination of leaders and implementers. They have invested quite a lot in terms of technical support and capacity strengthening at country level. They provide platforms for peer learning and exchanges between countries. They have driven the market shaping and procurement readiness agenda for new products, and really propelled and given momentum to community leadership and advocacy. And this is not exhaustive. It's just where there are commonalities across what these particular mechanisms have been able to contribute to the prevention response. Next. However, stakeholders had some recommendations and critical success factors that were identified, and we've summarized those into these 7 points. One is having a clear mandate delineation so that we can reduce the overlap of functions in whatever mechanisms we will have moving forward. Can we get rid of that, please? Thank you. And then having intentional linkages across whatever modalities will be there for moving forward with coordination of prevention through formal protocols across the different mechanisms. Country leadership, very strong, that countries need to be decision makers and not implement decisions that have been made. Community having more decision-making power and not only consultation roles. Financing was a major success factor that emerged, that whatever coordination mechanisms we move forward with need to be adequately financed. And the burden on countries was mentioned quite a lot, because different mechanisms call on the same resources at country level to deliver, to engage, and to report. So that country engagement needs to be less burdensome to countries and less bureaucratic. And of course, the political courage to address the legal, policy, and other issues that are still facing the key population's response at country level. Next. So some considerations for further discussion on these prevention mechanisms is, in terms of coordination, what would an effective prevention mechanism look like? And those of you who participated in interviews, you know, we asked you this question and you gave us some ideas of what a mechanism of or different modalities of prevention mechanisms could look like, but we still need to look into this a bit more. How do we clearly define the mandates of coordination mechanisms to minimize the duplication, but also the burden on countries that they brought so strongly? In terms of operationalizing country leadership was said a lot. What is it? What does an effective country leadership entail? And I think there'll be other questions we can ask about this, and Nduko will go into that a bit more. Community leadership, how do we move from consultation to decision making? We need the operational how, not just, we know it should be done, but we need to be very practical about this. And next, this is the final slide, Nduko, I can see you behind me. In conclusion, I don't need to say the funding landscape has shifted, but there was great consensus on the need for an above-country coordination. However, with ensuring that it addresses the overlaps, has a clear accountability framework. There is a consensus around prevention beyond LEN. Country leadership as essential, integration is inevitable, and service delivery innovations, including self-care and use of private sector platforms as well as virtual platforms. But as we move forward, it was also clear, and this is borrowed from someone else, is that we have to do ruthless prioritization. We can't do everything and we can't continue doing the same things. Invest in collecting, analyzing, and using localized data for prevention interventions, recognizing what's happening to our data collection platforms, and operationalize a fit-for-purpose coordination mechanism. And we also must reimagine and rethink the community response, especially the response for young people and for key populations. Thank you very much.
Wow, thank you very much. Thank you, Dr. Ode. Thank you, Dr. Wanjiru. Truly appreciated, and your thoughts are truly appreciated. For those of us who are online, I would just like to note that as we move forward, we will get to a place where we'll be having conversation discussion. We will ask you to put your chat, your discussions in the chat. In the spirit of innovation, we are not going to ask our panelists to come and sit in front of us. We said we are being innovative, right? We're going to ask our panelists to speak from where they are, isn't it? That's good, right? Excellent. So we are going to have an integrated panel. I'm really pleased because I want us to hold on to all our questions. I want to go to a quick sort of quick fire panel and ask some people some questions and have them reflect a little bit, but not just reflect, also give us recommendations. I think for all the panelists, the question was, can you please give us specific how-to and specific recommendations? And our panel brings diverse leaders. We have Dr. Izukanje, the head of HIV at the Global Fund. She's many of, I think almost everyone in this room knows whom we call Zuzu, Dr. Izukanje. Thank you very much. GNP Plus, Florence Anam. Thank you very much. I think GNP Plus is everyone knows GNP Plus, have walked the journey for a long time on the HIV response. I think we have Franca Thompson. Franca, you're there. Thank you very much. And Franca is a young woman who will be speaking with us today. We said she was from Ghana and just realized that she's from Nigeria. So you will allow us to call you, should we call you Ghana, Nigeria, or both work, right? Thank you very much. I don't know whether Dr. Galikan Ribasira is online. Dr. Ribasira, if you are online, just please let us know. He's from the Ministry of Health in Rwanda. And then we have Dr. Temitope, the Director General of the first female Director General of Nigeria's NACA. So over the next few minutes, I'm going to ask each of our panelists for some reflections. And the first, let me start with you, Zuzu. My first question to you is, in what ways does the information and the presentation resonate with Global Fund's directions around prevention? And especially, in fact, before I ask the question, let me congratulate you and the Global Fund on the replenishment. I think, thank you. I think it just reminds us that we still have a lot of support in terms of when there are, there will be some resources, certainly not the levels that we had or anticipated, but certainly not zero, isn't it? So thank you very much. And so over to you. Start with, we talked about integrated panels.
Okay. Thank you, Nduku, and thank you, colleagues, for the opportunity to be here and to speak on behalf of the, I'll keep it, don't worry. Yeah, great honor to sit next to Peter here, and he's offering to hold the mic for me. I've come up in the world, eh? Yeah, so the information shared this evening resonates very deeply with the Global Fund, and I think we've been seeing a lot of this over the last few months. And last week's UNAIDS report, clearly pointed out in black and white where we are and what needs to be done. So clearly there's a lot to be done. And I think I want to take a step back in terms of the Global Fund's approach with GC7 and some of the work that we had to do with reprioritization. As you're all aware, because of the changing landscape, changes in the timing of realization into some of the pledges that were made to the Global Fund, we had to undertake this really tough process with countries and ask them to rebudget their GC7 allocations. So going, through what we had allocated to them in their allocations letters and asking them to make those cuts. So this resulted in about $1.4 billion being taken out of the GC7 budgets. And as you can imagine, on top of everything that was happening, a lot of pivots had to be made, hard decisions had to be made. And this process entailed going back to the PRs and CCMs and discussing with them and figuring out what difficult decisions had to be made. Everybody wants to ring fence and support treatment. So keep the treatment cohorts going, scale up treatment where you can. But FODA did show us what happens if, we just go with treatment. We're not going to be in a good place. And given the tightening fiscal space and the need to transition a lot of this to domestic resourcing, we clearly cannot hand over programs that have an epidemic that is either stagnant or on the uptick or increasing. We have to be responsible and support countries and hand over a program that shows that the epidemic is in the decline. So with GC7 reprioritizations, countries sat hard and fast and made those hard decisions, secured commodities. We pushed to secure community-led initiatives or activities, given that a lot of this had been deprioritized due to some of the funding cuts and changes in the implementing partners. Our colleagues at Community Rights and Gender within the division that I sit spent a lot of time engaging with partners to ensure that critical activities or funding for investments that require community systems, community initiatives are preserved even with the reprioritization. So that is essentially where we were with GC7 reprioritization. And with this, countries have had to push their investments into initiatives that have high impact, cost effective, and will help the trajectory of changing the trends downwards. So it's not business as usual. We've had to rely a lot on EPI and local context, cognizant of some of the laws or criminalizing laws and barriers, and working around those and working with activists and communities to see how we can deliver services. And deep reviews of the portfolios were done. And I know we're very excited about lenacapavir, but we wanted to make sure that the message was not just about lenacapavir, but a review of the entire prevention portfolio and work with countries to decide what prevention initiatives they'll push forward. For instance, VMMC still remains critical and important in some settings, but in others, they've reached their saturation and they're kind of like in maintenance. So for countries like that, you're not expecting to see them push a lot of investment in building up community awareness or engagements around VMMC. Our guidance was channel those investments into other high-hitting, high-impact investments. Harm reduction remains critical. So what are we doing about harm reduction? How can we support countries to put investments towards harm reduction? And then the other thing that we did was lenacapavir and the 9 early adopter countries, working really hard with them, even though their budgets were shifting, to see how they could put some funds aside to allow for the introduction of lenacapavir. We do appreciate that the commitment that was made last year to get 2 million people over 3 years, we've received some pushback that we're just sprinkling a little bit. But this sprinkling is critical because what we're trying to do is shape the market, catalyze the investment, catalyze and invigorate governments, communities, and other partners on what's possible. So I hope that colleagues bear with us, and across the partnerships, what has been done can push the envelope in terms of getting additional resourcing and funding to have more lenacapavir. With GC8, we've spent a lot of time as the HIV team looking at our HIV info note and trying to ensure that it does have enough language or adequate language to reflect the realities of prevention. So for instance, program essentials now talk about making sure that prevention is prioritized. For instance, we have included as a program in essential screening for STIs and treatment and make relevant referrals for prevention services. We've included triple elimination of HIV, syphilis, and hepatitis around the vertical transmission as a program essential. We've also included, going by the WHO guidance, on intimate partner violence as a program essential. So screen for that and refer to the relevant offices or services. Integration remains key. We're not looking to support vertical or siloed programs, but integrating across the systems as it makes sense at a country level. So not as it makes sense to me sitting in Geneva now, but as it makes sense at a country level. So really pushing for that integration agenda, and then making sure that the partnerships are strong and not putting lip service to community engagement and participation. And more importantly, how do we ensure that the human rights are brought in, gender equity is brought in. So using those lenses in as part of the prevention agenda. I can see Duku trying to stand behind me, but not really. So I'll stop there. Thank you.
Thank you. There's a table that is going to dance for us. They know themselves, right? Okay, so thank you very much, Zuzu. And when I first stood, I wanted to ask you what about GC8, and you kind of just weaved into GC8. So we really do appreciate and thank you for that. I'll come back to you with a question. You've talked about integration, and the question is, what is integration for HIV prevention? Hold on to that thought. Rather, what does it entail? I would like to turn to Florence. And we have talked a lot about treatment as prevention. We have also had you a lot talking about collaboration with government as we move forward. Yet at the same time, we seem to have this question of we have to safeguard treatment, what happens to prevention? So please just reflect first on the comments that you had today from the two presentations, and then go ahead and tell us how you think that you can help as communities of people living with HIV bridge the divide between treatment and prevention, and especially now when we all have to compete for limited resources. Florence.
Okay. Good evening, everyone, and thanks, Duku, for these very hard questions. I'll start with the first one about reflections, and I'll just say this. I was just reflecting as I was listening and looking at Kode's presentation and Dr. Wanjiru's afterwards, and seeing population viral suppression on there, and seeing aspects of treatment as prevention, and seeing U equals U as and I think we've come a long way. That I don't think at GN were even engaged in the prevention conversation. I got a strange email from Dr. Matanje's office last year in November, December, and I was like, what? And I came in, and at that point I had to say, look, as a person living with HIV, my only contribution to this conversation will be talk about how we address prevention from the transmission side. That would be the only contribution, and the only power I have is to go and rally our community of people living with HIV and motivate using U equals U, how to get all of us on treatment. And we started to look at different things and become concerned, particularly about the third 95 and noticing how the number is not shifting. From the last Global AIDS report, only 73% of people living with HIV on treatment were virally suppressed. I have had conversations with a number of country leaders who allow me to ask them critical questions about how it's a problem for viral suppression. I mean, we look at the new infections in children as an entry point for vertical transmission prevention. And again, it's women may be on treatment, but they're not virally suppressed, mortality, etc. So I think for me, the fact that we are coming away from prevention was on one end and also treatment on one end, I don't think, frankly, from a PLHIV network perspective, we had engaged in this conversation. You asked me as well, I think in April, I was like, huh? Yeah, so it's so this is a good progress in and of itself. And if it's been brought about by the change and the need to be efficient, I think we are on the right track. To your second question about what I think we can do, we like to say, what can we offer? Next to me is my co-executive director. She sits at the back end and she's never seen much. Small wave. She will. Okay, so she's called Sbongile. But I think we've launched into this moment, and I like to clarify that when I hear the word treatment is ring-fenced, that's not what service delivery looks like for people living with HIV. Because at the service delivery point, things have shifted. When we go there, it's not the same even at that point. So it doesn't mean that the pill, getting the pill is even in the same way, or that is assured and its outcomes are assured. That is also still, I feel, something that we need to look at if addressing prevention from a transmission side is something we also want to do. I think the future of prevention has to be country-led, but I also think the networks have an opportunity with the structure that has been built over time. Country networks are very entrenched. They are connected to different platforms. They are offering, in so many ways, opportunities for education, for literacy, for media engagement, for connecting with the data and real-time experiences that can inform what is possible and what is not. I see an opportunity for people living with HIV networks to expand and look at broader health issues, not only driven from our need to access HIV treatment, but our need to address our global, I sit in the global office alone, but I meant our whole person-centeredness, because we are people with families. I mean, I got HIV when I got a baby who's 26 now. I would hate to be listening to him on podiums talking like I am now. I would love for him to have prevention, and those are things that must motivate us. It's sad for me to see new infections among young people and to know what life, and because we people living with HIV know. I've heard Dr. Mumbi say there's not enough information now about condoms in the population. And we know young people are not bothered, not because there's anything wrong, but because they are young people. We were also young and unbothered before. But we know, we who have been here and can be able to educate, motivate, and show. And I think there are structures that exist. And then finally, I sorry, I see Dr. Nduku starting. I think we can offer opportunities. I'll give an example. When the disruption started, I think I saw people living with HIV networks at country level being able to convene all the other networks. Along the way, young people networks have formed, key population networks have formed, and they were formed in order to cater to specific unique needs of people that definitely the networks of people living with HIV alone could not address. But the convening power, the ability to bring everyone together, because the network still at country level to the decision-making table, they can bring these to the voices together with them as they go towards policy and advocacy opportunities. I hope I've given a little bit of some offering for you right now. Thank you.
Thank you very much. Could we try again? Thank you, Florence. I would like to find out if Dr. Galikan, are you online? Okay, not yet, I think. So allow me then to turn to Franca. And Franca, I have a question for you. And you've had the conversations, the two presentations. My first question to you is to reflect on what you're hearing for prevention from your perspective as a young person, and make recommendations about what you think we all in this room should do differently or even think differently. You know, we might be having the mindset that my young people tell me about. So maybe give us some thoughts and suggestions.
On the two speakers who have contributed, I would like to say that for me personally, stigmatization is a serious issue. So getting more women and young women-led organizations and youth-led organizations to join in the fight, against stigmatization, which is also a form of prevention, whether we're talking about vertical transmission, PMTCT, or, individual building of their capacities through skill acquisition and all of that, empowerment of girls and women. I believe that we must get more involved and get more women involved, more young girls involved in this this area. And then also about comprehensive and affordable insurance plans. I believe that for me personally, because I'm also a medical personnel, I believe that affordable healthcare is key, because HIV prevention has to do with generally health services, assessing affordable health services, and HIV prevention is just an area, an aspect of health services. We have other areas. So for me, as a community, we must look into providing comprehensive and affordable healthcare insurance plans for people, especially those who are living with the virus. And then also I would like to add that we must get more community-based organizations involved. We must get community leaders involved we can't do it alone. We must get faith-based organizations involved. Because personally, I mean, for ICASA, I did an observatory research, and I tried to see how people react. And that's why when we have conversations around stigmatization here, I know it's real because I personally had an observatory research. When people, funny, but it's when people perception, when they perceive that you are positive, they don't know your status, but they perceive what's the response. So I believe, especially for faith-based organizations, we need to get them more involved in this stigma reduction because it's still it's high, the level of stigmatization in the faith-based community and in the community settings and among community leaders is also high. So we must get them involved. And then we must also promote self-care for persons who are not just people who are living with HIV, but generally SRH services for adolescents and young people. I work also in the area of abuse and rape prevention, which is GBV. So for young girls and women, we must also teach them how to take care of themselves because like I said, it's a general, package. The HIV response is just a part of healthcare. So we must teach women to have like holistic, self-care, take care of themselves, whether it comes to teen pregnancy, like the lady who spoke earlier, my co-panelist who spoke earlier about getting pregnant when she was, young people get pregnant when they are, 14, 13. So generally, whether it comes from rape, we know HIV and AIDS can be transmitted through rape as well. So I have a book written on that as well. So we must get young people to become self-aware and not be ashamed as Africans, young people, to talk about sexuality. I had that conversation with my niece recently, 13. So we should get to, involve them in the programming, the plan, bring them to the table, because it affects young people. If we just leave them at the other end of the table and say, okay, we just give them money, we won't really get to listen. I believe it's about humanity. For me, it's about compassion. So we must get them, into the planning, programming, budgeting, critical thinking, whatever aspect of prevention, we must get them involved. And then for integration of services and strengthening of existing health services, health institutions as well, we must get that, in place. Integration of services, strengthening of services. I don't want to go into all of the personal, because I share stories a lot, but I mean, we need to, especially, I have heard over time in this conference, over and over about attitude of personnel in health facilities. For me, these are practical, and these are real things I've experienced. Attitude of men. But recently, I was really excited to see the WHO and the Ministry of Health for Africa, and especially for Nigeria. They have training programs in place to equip medical personnel, especially because if we're talking about accessing healthcare and health services, then the attitude. I had that session this morning where a young person talked about in Ghana, and it's true. I mean, like, we must have friendly, warm, loving medical personnel or healthcare providers in these institutions who provide quality care. And then I would also like to say that we must avoid parallel programs, not divided. We must have a unified program going forward. And then we must stop depending on just donor funding. Like, I've done this for over 20-something years. So everything we're saying is true. We must look into resource mobilization for ourselves, like generating income within ourselves. I mean, I have basic first-hand experience about my governor, my state, Delta State in Nigeria. They haven't borrowed any money. Like, in his tenure, he hasn't borrowed. And the governor of Accra Ibom State as well, they have a policy of no borrowing. Let's generate our own resources, looking works, and so we appreciate donor funding. But for Africa and countries around the world going forward, I believe that we must put savings culture in place, because it's very important, generating income to sustain these services. Thank you so much.
Thank you. I'm very happy. You can see me smiling because we all clapped. Thank you very much. There's so much coming out, but before I kind of try and pull it together and then ask you all to reflect on all of this, sort of amazing, interesting considerations, I want to ask one more speaker, and that is Dr. Ilori. Dr. Ilori, I think the first question to you is, you are a national leader and you lead one of the largest responses in Western Africa. And we have talked a lot first about prevention. We've heard about choice, success. We have also heard about what countries and actors are saying about what could be done differently, what needs to be done differently. So the question for you is, first of all, to reflect on what you have heard. And then the second, tell us from your perspective and where you sit, what are the 3 key recommendations you would be making for us in this room? Thank you.
Thank you very much. Good afternoon, everyone. Well, when I came into this room, I was asking Nduku, I was like, did you send me an email on questions to expect? Because I don't think I got any. And she was like, no, they're just reflections. But now she said some questions for me and I will just try to answer. Well, let me start by saying that I join others to say that we really need a comprehensive prevention strategies. These days when you talk about prevention, everybody's quick to talk about PrEP and all that, which is quite, actually the new innovation. Learn PrEP is quite a bit of an innovation, and it's a welcome development, which we're quite happy with. We also agree that we should actually have holistic, comprehensive approach to prevention, including all that has been mentioned, PrEP, PEP, condoms, and other treatment and other prevention messages. I'm glad to say, like I'm always proud to say it, that there's nobody on the continent that has the population that we have in Nigeria. We have over 250 million Nigerians living, and therefore that dictates, our prevalence. Our prevalence is just 1.4 million, but that means it's about 2 million Nigerians living with HIV as we speak. But we seem to be doing well, if I can say that by myself. Our figures is 87%. It's 7, 98, 95. So I think we're doing fairly well for that huge population, and having a country that has over 36 plus 1 state. So to have that kind of figures, I think we're on the right track. But be that as it may, we have challenges with the youth, with the youthful population. Nigeria is a very youthful country. We have about 30% of our population less than 25 years of age. So we're beginning to see that the issue of prevention is not high up there. That population of people less than 25 believe that HIV is just a myth. The studies that we've done shows that over 55% of this youthful population do not have comprehensive information regarding HIV prevention. Many of them are not. The use of condoms is declining, amongst the youth, particularly, and interestingly, even amongst the key population, which, of course, contribute about 90% of the new infections we're seeing. So we really have to be more aggressive with the prevention messages, and that is what we're beginning to do now, and using all the different strategies, to ensure that we have a total market approach. So that is what I want to say. And of course, like I said, for in terms of, what was the question? Sorry, what was your last question? I said 3 for this meeting. 3 recommendations were, I would say that, like we said, comprehensive approach, total market approach. Let's target the youth, because Africa generally, I think we have a very youthful population. Let's carry the community along, like everybody has said. We should have the necessary awareness, demand creation, demand generation, using the right strategies. Let's ensure that we strengthen our health facilities or our institutions generally, because we're going to leverage on them anyway. And of course, country ownership, country driven approach as we go forward. I think I've been able to answer your questions.
Thank you. Thank you very much, Dr. Temitope. I think we have had a lot. But before I ask us to kind of react, because I'm sure many of us want to say something, isn't it? There's reflections that we have. I would like us to just in the groups we are sitting, just have these reflections there so that we can actually bring them to the fore together. And in those groups, I want as just listening to our various panelists from our integrated panel, that I've had a number of things. One of the things I have had is youth, demographics, populations. And I think what I'm hearing here is we have to recognize that we have a new, who was born after 1990 in this room? Yo. For the record, not before. English, not before. I think there is only one person after 1990, right? We just stand up, please, if you don't mind. Now, after. Oh, get out. Oh, of course. Now, thank you. Please, you can sit. You can sit. When I think about a point that has happened is that whatever we are going to discuss, and because we are going to have some reflections, we must think not of ourselves here. We must think about that group and the younger ones. That's the first thing, because that is prevention in the future. If we are not thinking about that, we are thinking about prevention in the past. We are imagining our prevention. The second thing I think that I have had today is self-care. We need people to somehow take care of themselves, find ways, give them options and opportunities for self-care. Maybe we need to ask ourselves, what does that actually mean? How is it delivered? By who is it delivered? How do we make that work for this generation that is not us? I have also heard the word integration a lot. Almost everyone talked about integration. Have we actually defined what that means? I have had country leadership. And the thing is, I've been hearing country leadership for, I think, 20 years now. So what actually entails country leadership? How do we measure country leadership? I have also heard words like affordable healthcare, ability to afford healthcare, insurance, and so on. I had something that we haven't talked about. I've only had that word once, actually, since I've been here. Faith-based organizations. We are a community, or at least most of our countries are very grounded in different religions or faiths. So the question is, are we harnessing that? I have had questions around persons living with HIV and how they become part of the solution for prevention. Even as we think about LEN, how do we leverage persons living with HIV around PMTCT? In LEN, how do we leverage condom programs? So I think those are areas and issues that we need to have a bit more reflection on. In order to have those reflections, because sometimes it's not always for all of us to talk at the same time, we have some tables. So who wants to be table one? I'll not show you the marking scheme. Who wants to be table one? Just any table. Table one? Thank you. Table two? Table two, thank you. Table three? Rosemary. Table four? Thank you. Table five? Thank you. Okay, we still have one more table. So we will have a table 6. But I want us to reflect a little bit. And the first table is going to talk to us about, is going to think over the next about 20, 30 minutes. What is country leadership? What are the specific operational features of that thing called country leadership. What are the elements of country leadership? We are going to give this to you so you don't have to write all the questions. And what metrics can be used to measure country leadership? If we are talking about country leadership, we have to be able to measure it. So perhaps we can give this to table one. Table one is right here. We can share this plus, yes, plus the other, yes. Then I want us, who volunteered for table two? Table two, that table right there. Okay. We've talked a lot. I've had almost every panelist talk about, yes, table one. Okay, hold on, table one, hold on. Table two, we've talked a lot about what we need to do. But because we don't have all the resources that we had to do everything we need to do, we must also talk about what? What we must stop doing. Isn't it? We just want to keep doing more and more. In the current context, we can't, isn't it? So I would like table two to ask ourselves, priorities and prioritizations have been mentioned continuously. Priorities, prioritization, countries must prioritize. So you have some questions. What tools do we need or have to help in prioritization at country level? What must we continue to do? But most importantly, what must we stop doing? I think we were told ruthless prioritization, but I also want to note that part of the reason we are having challenges with prioritization is because we all have interests. So what I'm asking is we put the interests aside, which is very hard, but it has to be done if we're going to be successful. Number three, we've talked about HIV coordination, and there are two levels of coordination. There's in-country coordination, but there is also above-country coordination, sort of cross-country coordination. And so I have some questions for table three. I would like you to describe a desired model for across or above-country coordination mechanisms in a reimagined future. And the questions is, if you were to design such a model, who is group three? Oh, right there. Propose the functions and the operating modalities, the structure. Give us specific recommendations. Because you're near me. Okay, so table four, what should countries do? Enhance in-country coordination for prevention. Because it's not just above country, it's in country as well. We have different actors. As I've said, they have all different interests: government, CSOs, communities, private sector, faith sector. How do we enhance in-country coordination? Hold on. Group three, hold on. We have group 6. So group 5. Group 5, the question to you is, HIV integration is something that we have talked about. It is essential. What should integration entail? Now, for table 5 and 6, you're going to share this question because there is integration and HIV self-care. Table 5, you're going to focus on integration in the question. And table 6, you're going to ask yourselves, what should self-care for HIV prevention entail? What are the elements? How should they be delivered? Who should deliver them? If we are going to make self-care a reality. Can I have another table,
You have two? Please. Need one more? I need, hold on, I'm doing some logistics here. Now I'm being given additional questions. So because we don't have much time, okay? I'm going to give us, how much time do you think we need? 5 minutes or 25 minutes or 2 hours? No, not 2 hours, surely. Okay, so I will check in 25 minutes. This class is not listening. Okay, start. That's the easiest way to do it. Now, we have an online group, and for the online group, our request to you is that I will talk to the online group in a second. In each of the groups here that are physical, please get somebody in your group who will do the reporting. We are asking you. In many of the groups, we are also, I think, we have organized for the recording. So have a conversation, and in 25 minutes, we are going to check in. Okay, 1, 2, 3, go. Start talking. For our online team, we are asking you to reflect. We are asking you to put it in the chat, and we'll be asking you to, anyone who has additional contributions, to please be able to share those contributions. Thank you.
Hello? Hi. Did you say?
No, no, no. Just hi. Hi.
Just hi.
No, no, no.
Yeah, yeah, I think.
Don't disturb. No, no, no.
No, because they're about at the end.
You know,
Yeah, yeah,
It's the head of your business.
Just you have to rethink it all. You know, now they start talk coordination with UN agency. I said kick them all out. Have private sector.
Yeah.
Yes.
Very.
Okay, give me a second.
Hello?
I'm just going to interrupt for 1 second. We have a guest who is on their way out. Just wave as you chat. Just wave as you chat. And because he won't be staying, unlike, so we shall just ask you to.
Oh, thank you very much. I think I am used to be unbooched. And I just came to see this young man quickly, and he said, no, 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 you have to come. But I didn't know that it was one of the most important subjects. And this discussion should not be here. It should be with ICASA there, because they are lacking completely this strategic vision. I don't think we started together with you when we launched this prevention, and we try to, but I think we need in this specific period of time to shift completely the paradigm. The traditional paradigms, which was there even on prevention or even dealing with our communities, even placing our community at the center, will not work anymore. And the traditional relationship with UN or with a state will not work in the same way. The traditional relation with also private sector, which will not be anymore the same. So I think the paradigm need to be rethinked. And at that shift, you need to make sure that prevention will not be just individual behavioral change, but it need to address social practice, how things will be addressed in community, in a practice level, because individual behavior is fantastic, but is also, you can know that more than me, is influenced by social practice.
Thank you.
Thank you very much. God bless you. God bless you.
Thank you. Sorry to have interrupted. I think that's it. Yeah. Sorry to have interrupted. Please, we may proceed. We may go ahead with our discussions. We apologize for the introduction. Okay, we'll give you 3 more minutes.
Harris, we are ready to report, right? You have 1 minute? 2. 2 more minutes? 2 more minutes? Yes.
But we will.
There are some tools and there's some guide. Keep going. Oh, Micho, sorry about the snacks, but yeah, sorry, we didn't get there. Keep going. Is that it? Okay, thank you very much. Okay, you can just close the chat. I would like to see if there is any comments. Any comments? Close the chat, please. Those of us online, I would appreciate if any of us has any input or comments. Okay. Going one. Going two. Just unmute if I can't see your hand. And just start talking. Okay. Going three for now, and then we'll come back before we close. Thank you. So I would like us to start with, just having a reflection, and each group to tell us what their reflections have been, and then what they have discussed, and the recommendations they have made. Each group has 3 minutes. Or should we make it 2? Okay, 2 minutes. Who wants to start? Okay. Table 1. Okay, go ahead. Table 2 has decided to start.
All right.
Your question and your questions, and then your
presentations and panel contributions. Priorities and prioritization have been mentioned as an essential in the current context. What tools do we have or need that will help in prioritization at country level? What must we continue to do? What must we stop doing? So for us, in our reflections as a group, we looked at the transmission component and also the acquisition component for HIV. And as such, that drove us into looking at the priorities. So the priorities that we're looking at was prevention amongst the high-risk population, including adolescent girls and young women and key population. We also looked at domestic resource mobilizations and the models that we could use. We looked at care and treatment, essentially looking at how we could save lives with our care and treatment. We looked at robust and evidence-based community engagements, because we know that the community play a great role when it comes to response and also in treatment and care. And we also looked at prioritization tools in country and what were the tools. We all have data. So the use of disaggregated data is key to driving whatever we prioritize, and community participatory analysis tools that are also used can help with prioritization. Then what do we continue to do? We must strengthen multisectoral response. There's need for us to think outside of the box, have a shift where we create youth digital hubs which serves like a one-stop shop, that the young people get prevention in those hubs. They get there to play, they get there to engage with social media influencers. We're pushing a lot around prevention, a lot around the social behavior change that we want them to have, the knowledge that we also want them to have. We have an example from a member who, using youth digital hubs, was able to reach 10,000 young persons in a day to provide accurate information. Also, we looked at engagement with vulnerable groups, that we should continue to do that. We also should continue to look at innovative ways for domestic resource mobilization. We talked about engaging with the private sector, having marathons to raise funds. So doing things quite differently, not bringing everybody into the room and sitting and saying we're raising funds, but having marathons, which we know, and then bringing the private sector to be at the forefront of these marathons that we do have, looking at taxes as well, and also even looking at how we can have like music concerts, because we know most of the big wigs in terms of music industry, they do a concert, they raise 1 billion. So let's, you're looking at leveraging into such. You may look like we're going into the play thinking, but the play thinking does bring money, and that's one way we also looked at it. But then we looked at having community-owned programming where we do own our program. We should also enhance inclusivity in our planning. We looked at us embracing and leveraging AI and data analytics to anticipate HIV risk trends. And we talked about advocating for HIV prevention to be part of the national health insurance and engagement of decision makers. We need to speak their language. Many of them have a language that we must come and say to them in the room. What if 160,000 people are dying because of HIV? If you put in $1, it can help you save so number of lives. They don't want to hear our rhetorics, but they want to hear those numbers and how it can help with the economy and what it can bring to them in terms of their national economic growth. What should we stop doing? Let's stop silos approach, let's stop donor reliance, and let's stop late inclusivity in planning. Do not bring those that we're programming at the end. Now we know that there's a crisis. We must engage them now. Bring them to the table. We're talking about all of these solutions. We must bring them to the table and let's hear them out. It may seem that their solutions may be rudimentary and may be crude, but we could refine what they bring to the table. Thank you.
Thank you very much. No, that. Thank you. Thank you very much, Dr. Bosire. Okay, you may switch off the mic. Okay, yes. Thank you. Next, another group. Well, they're already here, so they already had their hand up. You'll allow me. Okay, go ahead. No, that was not country leadership.
Am I audible? Yeah.
He already has his mic on. Let him finish. Go to self-care.
Yeah. So just to, hi everyone, my name is Abhijit. I'm from GNP Plus. By the power vested in me by Dr. Ndugu, to call me myself as a young person and sitting with all these old people. They had a lot to say about how young people self-care should be. I heard and I thought as a young person, I should speak for myself. But then when they spoke, they had some points which I thought valid. So I'm going to speak from that point of view. So from the element of self-care, one of the main points we discuss, as everybody knows, that is knowledge and awareness for the young population. How to create knowledge and awareness among the young population. Second one is choice and agency. How the young people have the choice to select what prevention they want. What are the preventive care models they want. And the agency to choose which healthcare system. For instance, how easy accessibility is, how affordable it is. Do I have it in the places that I go? Because it's about how religion, faith leaders, how we can involve them. But the question I asked, do you think that we go to religious spaces regularly? So if you keep it there, how are we going to access? So to identify those spaces where we go or where the young people are, that it can be digital spaces. It cannot be a physical space. It need not to be a physical space. It can be a digital space. So how are we going to engage those people? And the decisions for self-care has to come from the young people instead of telling them what to do. Another point we discussed about the environment. Are the policies placed? Are the environment surrounding the younger people? Are these more of an enabling environment, or are these more of unrestrictive environment? So the self-care needs to come from an enabling environment side of it. And the quality of the products that offer to the young population. Are the young population ready to use those products which is healthy for them? They think that which is healthy for them, which they think that it's usable for them. So we need to think it from that perspective. Then coming to there's a lot of points these people said to me. I talked about already the location and the rapidness of the results that I get. Do I need to still go to an exclusive healthcare system where everybody gonna look like a Gogo, that guy or that girl going to that space? Or is it in a space where I can easily get without having any prejudgmental notions? Then we also spoke about a PLHIV point of view. As a person living with HIV, do I also get to be not tired of my own treatment? What are the self-care that as a PLHIV I'm going to get? Because that is where the important point of U equal to U comes in. If I'm not adhere to my own treatment, I'm also going to be in a risk. So I'm the famous call of, am I going to be the lost to follow up, and then am I going to be a reinfection risk? So there is a point of that. Then the treatment adherence, and also these points of encouraging disclosure to the partner, or U equal to U, is also come from a point of self-stigma. If I am stigmatized myself, I'm not going to disclose the information. I'm going to keep that information to my partners or anybody. So that is where the PLHIV point of prevention comes in. The PLHIV also have an equal stakeholder than along with the people who we are trying to protect in terms of prevention. So we need to take care of both those aspects, and that knowing the status. To as a PLHIV, I should have that courage to encourage my partner, to educate them, to give them knowledge about how you are going to know your status. I think those are the major points we discuss. And then one important point that stand out to me from the old people was how are we going to keep the healthcare equal to happiness? Healthcare has to be happiness. For young people, we look for the vibes, and the vibes has to match with the happiness. So I rest my case in my 2 minutes.
What's the vibes? Thank you. So healthcare equals what? This equals vibes. Okay. Next, they asked. Because they asked, let me allow group 4. Okay, go ahead. Sorry, group 1.
Okay, so
Group 1. Group 1 on the screen.
One was on campus.
Okay, thank you.
So the questions reflect on the presentations and panel contributions, and then describe country leadership. What are the specific operational features? What are the elements of country leadership? What metrics can be used to measure country leadership? So in terms of the description, we talked about the country's ability to set their own goals and priorities that are informed by evidence, and that the priorities set by the country are the ones that truly drive implementation, and that the country's leadership is felt at all levels of the government, from national to subnational and community, and also across the various sectors of government, and also at the technical and programmatic levels as well. It also means the country's ability to really call the shots politically, financially, and in terms of the ability to enact or influence their own laws and policies. So in sum, we said it should be country conceived, country initiated, and country led. In terms of the operational features, we looked at the political levels, the executive, legislature, and judiciary. We also talked about leadership in terms of the programmatic or service delivery level, and also at the community leadership, including also the traditional leadership and religious leadership. On the second question, the elements of country leadership, we talked about governance, strategic planning, resource mapping, mobilization, allocation, and so on, goal setting, operational framework, accountability, transparency, integration, and broad representation. And here also we concluded by saying that legitimacy is really key to a key element in terms of country leadership, and it's really about the country's ability to call all stakeholders to account, but also to be accountable itself. In terms of the third question, the metrics for measuring country leadership, we mentioned 7 key points. The availability of policies and guidelines and the use of these guidelines across the country. Then the country's performance on key programmatic indicators from prevalence, incidence, and so on. Then also the resource availability and allocation for programmatic implementation. We talked also about accountability. Then we looked at enabling laws and policies. And then we also looked at the community leadership. And finally, the political commitment. And political commitment, we said it can be measured in terms of the levels of functionality of institutions, the regulatory frameworks, the how functional the coordination mechanisms are, and so on. So this is it.
The group that is going to sing is the one that told us we must clap.
Thank you very much. The next group, which group? Yes, that was group 4, 5. Group 5, let's go to 5, integration. Thank you, go ahead.
So group 5, our question was, what should integration and self-care for HIV entail? And we were answering the first bullet. What are the essential elements of HIV prevention integration, and where should integration be done? So on the first part of elements, the first element was combination prevention as integration. And of course, here we were looking at both the non-medical and medical aspects of combination prevention. These need to be integrated. And then there was also the second element is basically doing it through a systems approach, which looks at the service, clinical, community facility, supplies chain dimensions, all of this brought together. And then the third, and which was our last on this, was knowledge sharing with all its dynamics and complexities. So when you talk about knowledge sharing, you come to realize that, of course, while we are sharing knowledge, there are people who are also spreading misinformation on what we basically are trying to do. So it's knowledge sharing. And of course, there are places whereby there's some ignorance. Yes, we are trying as much as possible to ensure that the communities understand. So in all its dimensions. And the second part was where should integration be done? So integration should be done one of them should basically be with the resources, with the resources we have in the country, and of course look at the resource in all its entirety, HRH, finances, whatever, the facilities that we have, and then of course, when you look at HRH, we should not also forget the community health workers, and things like that. And then also we look at it in terms of programmatic, structural across the different diseases. And then the other one was community, it should also be done at the community. You have also these particular aspects of co-location, where we are basically co-locating some of the facility resources or, And then there is also at the facility itself. And then this was very, very important indeed. Multi-sectoral coordination, governance. Of course, trying to recall exactly what the original function of the NACAs were in the countries. And of course, this was important also. We extended this particular discussion, looking also at the PACAs, and we were also looking at it in terms of maybe if at all, let's say we could be able to reduce that particular territorialism that maybe sometimes brings a bit of tension, and of course maybe brings a bit of inefficiencies, and of course trying as much as possible to bring that particular harmony. Thank you.
Very good. Thank you very much. Okay, group 4, go.
Oh, hello, can you hear me? Okay, so actually we represent a table where 33% of our members so you will understand that it takes a bit longer for youth to express themselves, and also that Daktari has now classified me with my 4 years into the oldies instead of the youth. So I narrowly missed the cutoff. That being said, we had really interesting discussions, and looking at the reflections within our group, we thought the first priority really should be solidarity, an approach of solidarity that takes place within countries, across all levels of the country, sectors, but it should also take place between countries. It should be an approach that looks at cooperation instead of competition, because when resources become scarce, we have to really start learning how to share and not to fight. When it comes to the additional reflections that we had, and though we hear a lot of the same things, again, we thought, what else can you do beyond that? What innovation can you come up with beyond that? And we said, as harmonization and integration occurs across the African continent in different regions, what about looking at ideas of carrying out pooled joint country level procurements together? So Kenya, where we're from, could combine their procurement with Uganda or with Tanzania and say, hey, let's do a triple procurement and fight for these prices to go down even more based on that volume. But then we said as well, what about if we look at negotiations with the raw materials, with the manufacturers? Can we be at that table when they're negotiating so that we can bring the prices down further? What about looking at establishing manufacturing facilities on the continent that can serve our populations here? If you look at the cost of establishing a WHO-approved facility, it's about $10 million. To get a super one, you're talking maybe $50 million. And this is just a fraction of the funding that's been allocated. So if we look at our internal options, why not supply our populations from what we can make here? It's a high-level discussion, but AU, regional partners, can all have these discussions. So coming back to the second question, what should countries do to enhance HIV coordination? So first, we said that there should be HIV coordination units that can actually work through existing structures. They can also determine the matters of prioritization within the country, because one country may have a different priority as opposed to another country. To take a cross-sectional M&E coordination approach, so we can share data as well. Community engagement to be involved for ownership. Daktari, I did say youth take a bit longer to express themselves. So community engagement to be involved for country ownership and to give local prioritization. Institutionalized coordination. And lastly, decentralized coordination authority to district and communities so that they can also be part of this ownership and transformation. So that's it from us. Thank you.
There's a singing group that refuses consistently to clap. Let's go again. Thank you. Thank you. Last group. Group 3?
Not working. It's on.
Okay.
Goes on and off. Okay. Hi everyone. My name. Okay. Hi everyone. My name is Elizabeth Atieno. I am also from GNP Plus, not as funny as my colleague though, but I'm going to present for group 3. We were discussing about HIV prevention coordination, and these are our reflections. And my colleagues will also help in chipping in case I leave anything out. So how do we coordinate partners within countries? So reflection. How do we coordinate partners above countries to allow for better allocation of resources? Recognizing that support is through different domains like funding and technical assistance, bringing together all the different partners in the coalition and making sure that the structure is clear on the different roles of partners within the coalition. And also we discussed on how do we create national coordinators who include other crucial partners. Okay.
Group 3, are you done?
Yes.
Okay, please.
Yes. So, so we spoke on the how, and the how was to have a joint plan that everyone can contribute to with different actors coming in with their own agendas. And at a time when we have limited resources, bringing in private sectors, not just for resources, but partnerships for strategic coordination. And we also shared that we should map out private sectors and other partners that go beyond the traditional partners that we are used to. And there was examples of other private sectors who included from private sectors from different levels. And there was someone who mentioned an example around involving partners from, let's say, for example, salons. And we also spoke on the coordination mechanism that sets prices, inform messaging, and a system that allows CSOs, farmers, and private sectors to be equal coordinators within the above country coordination, and also have a coordination mechanism that should be able to remain relevant even when donor funding is not there. And then lastly, to have a platform of mutual accountability within each partner, having different responsibilities, and have a platform that encourages knowledge sharing. And I'm going to pass it over to my colleague Asina to speak on the proposed functions and structures of the above country coordination.
Thank you. 1 minute, Asina.
Sorry, 1 minute.
I'm standing behind you.
Okay.
That's how it works.
Thank you. So I think the proposed structure that we had discussed was to come up with a mechanism to bring together all role plays above country level. So looking at donors, looking at UN agencies, pharmaceutical companies, whoever is providing support to countries to come up with a structure that they all work towards with a single agenda. And making sure, so if we're talking about an HIV prevention agenda, everybody then subscribes to that single agenda with a coordinated plan that everybody contributes to, in a nutshell.
Can we clap properly? So I shall be retiring because this is about, my job was really to have us have a conversation, to have us listen, have conversations. It is now my very, very humble pleasure to do two things. The first, just before I call on my chair, is to acknowledge. I think we had Michelle Sidibe say hello to us, but I think it's also important to acknowledge Professor Dr. Baron Peter Pio, who has been here with us the entire time sitting, who is also was the executive director, actually the founding executive director of UNAIDS. Thank you very much, Peter, for being part of this conversation. It is now my pleasure to be able to do two things. Well, I've done the first thing, to hand this over to the chair of the HIV Leadership Forum, Dr. Tembi Sileng. Sorry, Sisi. So I want to say that as I hand over to Dr. Tembi, I want to also say that I will be leaving you all in a minute. And thank you very, very much.
So before you leave, Ndugu, my name is Tembisile Olu. But let us clap for our moderator. But before you clap, I think you really steadied the discussions. You ensured that we remain focused, insightful, and you were quite respectful of the complexity of the vibes versus the generational divide. So let's clap for Ndugu. Thank you so much. All right. Thank you so much, ladies and gentlemen. I'm aware that time is against us. We're supposed to be done by 7:30. I'm going to ask two people to give us closing reflections before I give closing remarks. And our first one is Rosemary from UNFPA. Thank you. Thanks, Rosemary.
Thank you very much. Professor is no longer around to stand behind us. I think I will stand on the established protocol. HIV is essential for sustainability, and for sub-Saharan Africa, HIV is a socio-economic development imperative. And as a matter of fact, in Eastern Southern Africa, we believe that if we don't address HIV, several countries may fail to reap their demographic dividend. So we are sitting in a very historic event for the next 4 years. But what prevention are we talking about? It's combination prevention, as we've had in this conference. Behavioral, biomedical, structure. It's beyond one product, and I hope we take that home and understand how it fits in. How we fit it in from a UNFPA perspective is the people-centered kind of approach, a focus on a choice, on a package of choices, and realization of rights. And I hope that the prioritization we are talking about, ruthless prioritization, is looking at the ability for a beneficiary to access a package of choices, not necessarily looking at which intervention to pull out, but how do we deliver that package. We believe that HIV is integral to sexual reproductive health and rights as per the Lancet definition. And we propose that as we discuss integration, we do consider a good focus on how to hinge HIV prevention on the SRH platform. It has already been doing HIV prevention, but unfortunately, since prevention was vertical, the reporting was not very clear. So this is a low-hanging fruit that we believe can be harnessed on the primary healthcare platform, which is quite big. We do have a joint program on SRH HIV GBV integration in one of the regions. And I want to say that integration is a massive undertaking. And it starts with actually the mindsets. I think one group brought this up. It's not going to be easy to take back HIV where it should have been. And we have to prepare for that. And yesterday I had someone mention maybe the NACS should be a department in the Ministry of Health. I think that's a dangerous statement at this moment if we still want to do multisectoral HIV prevention, because we need to first organize ourselves in these 4 years and perhaps by 2030, then hand it over to something. Integration is big, and where systems are weak, it will still remain a dream. I did mention that part of the reason you've not seen HIV prevention on the SRH platform is actually the data systems. Nothing picks the prevention that we know in the institutionalized data mechanisms. And therefore, what do? How do we pick that? How do we hold ourselves accountable for the results that we want to see on the institutionalized platforms? Aspects around converging supply chain management systems. We have RH moving its direction, we have HIV, we have others. Who is going to pull us together to converge these to harness the efficiencies? Same with human resource, and let's not just think health worker. Integration demands a focus on human resource at planning, policy level, and so on. Some of these we already lost during the funding cuts, and it's going to be imperative that we understand how we bring them back from an integration perspective. I just want to add that we, on a sad note, UNAIDS sort of the footprint has reduced, and we relied so much on UNAIDS for HIV prevention. But we have not fully exploited the UN platform at country level for supporting countries. HIV, UNFPA is still a lead on HIV prevention, but together with the other agencies, we have platforms that are already in place that can be exploited to provide technical assistance. We have platforms in UNFPA that we can use to convene development partners and see what we can do with national governments if we are to support institutionalized action. It's difficult for us to imagine that we can sit at global level, we discussed coordination, and make things happen at country level. You need a pair of hands, a face that is seated in the room all the time to merge the thinking at global level, the directions that we have with what the country is doing within the context of that country. And I invite you to use the UN platform in a joint manner, not separate. So I want to end with reimagining community engagement. This far, community-led monitoring, community-led responses has been specific to HIV. I can say not even SRH has been on that platform. And we need to understand what we mean when we talk integration in terms of community engagement, because many processes are already running that we were not riding on. I hope we are not going to take this single kind of approach on the integrated platform, because we may not be very welcome. We need to understand how we work with communities to integrate into what they are already doing, like the youth have already mentioned, and then use those platforms for community-led responses as part of the multi-sectoral approach beyond the health system. I think those are part of my reflections from what I've been picking.
Thank you so much, Rosemary. So if you don't clap louder, I will dance and you will cry. You will cry. All right. Thank you so much, Rosemary. So I think we're really starting to get a sense in terms of HIV prevention integration. And part of what is coming across is that every contact, every visit, be it community, be it an interaction online, be it at a facility, must be an opportunity to offer prevention and to meet a patient or a client holistically, to screen them for other risks, not just related to HIV, but to prevent further disease progression for diabetes, for hypertension. And it's really, really coming through that we are not just caring for the person, but we're making sure that a client leaves protected, not just treated. I'm going to ask one last reflection from Dr. Professor Jürgen Pillay from the Bill and Melinda Gates Foundation. Professor Pillay, please. We said we are being innovative, but I'll ask you to come to the front so that people can see you.
Thanks very much, and good evening, everyone. So I've got 8 points I'd like to make. The first two are really little anecdotes. Peter, Piot, Nelly, and I went to visit a facility this morning, just outside town, and we met the folk who are running the ART clinic, met the people who are running the TB clinic, and next door to those two consulting rooms is a third consulting room, which is the wellness center. It's a walk-in center. You can get a breast exam. You can have your blood pressure tested. You can have your blood sugar levels tested. You can have an HIV test. You can have a TB test, all in the one place. So, you know, there are interesting examples on the ground in clinics where people are trying out things. So I think it's very useful for us to look at these organic experiences and review them and build them up. Second anecdote is from my friends from GNP Plus. So they had a group of youth, and they can tell you the story themselves over dinner. They had a group of youth and a group of, I won't call them elderly people, adults, right? Some adults. So they asked them, you know, and these are, of course, HIV positive folk. So they asked the youth, you know, what kind of social platform would you like to see? And can anyone guess what their number one ask was? A dating platform, right? Because they said it was very difficult to date because of still the stigma attached to being HIV positive. Then they asked the adults, same question. And guess what they said? Aging. We want information about aging. So the point is not about aging or dating. The point is we've got to co-design these with the people we are designing these systems for. And that's the kind of point of that anecdote. So thank you very much for sharing. Third thing I want to say is that there were 6 papers that were written. Some of the people, some of the authors are in this room. So thank you very much for the authors that wrote these 6 papers that are part of the Lancet series on HIV prevention. I unfortunately was asked to review all these papers, so I've read all 6 pages, but they're very good in content, excellent examples from Africa in terms of what countries are doing. So I would really encourage everyone, especially the Leadership Forum, to look at these papers, because I think that there's a mindful of information in there. The fourth thing I want to say is I really liked the issues around ruthless prioritization, because I think, you know, we just have to think carefully about and with much more intentionality about what we do and what we don't do. And equally, I like the 5 Ps. I think the 5 Ps are a good guide to what we should be doing and what we should be stopped doing and how we should do it. So it's people, package, place, platform, and price. For many people, price is number 1, right? But I think we should consider price with respect to how user-friendly things are. So that was my number 4. My number 5 was, I think it's very important, and I really like to thank GNP Plus for raising this, that we've got to focus on both acquisition and transmission. So we get away from this division between prevention and treatment, which is really an artificial divide. So in order to remove the friction between them, I think if we talk about acquisition and transmission and stopping both, will be the way we should do it. So thanks very much for raising. That was my number 5. My number 6 is the use of technology. And I really like the youth digital hub. You know, to get 10,000 people in a few hours or days is like marvelous. So we need to think about how we build up these hubs, which might be hubs for different constituencies, different cohorts, people with different needs, etc. I'd really like to thank the folk that did the review that was presented on what we should be doing and what we should stop doing, etc. It's good guidance for the foundation, which we need in terms of what we fund. And I think it clearly brought out the tensions that we need to resolve between country and donors, between LEN and comprehensive prevention services, between what kinds of platforms we need at different levels, global, national, subnational. And I think the issue that they raised about how to use the LEN momentum for prevention writ large is very important. And I think, you know, one of the things, and I'm sure Peter will agree with me, one of the things that the visit to the facility reminded me of today is that we have to think about prevention writ large, not just preventing HIV, right? So we've got to think about that because we're integrating prevention, HIV prevention into prevention of other things too, right? And the one thing I want to challenge the Leadership Forum around, and I know some of the countries are already doing it, is to think of the Leadership Forum beyond HIV, right? So the NACs now need to be, I don't know what you're going to be calling them, Tembi, right? Because you can't call them NACs anymore. Got to think about it outside the NAC, outside the box of the NAC. And then the final 2 things I want to say is, Fode, you showed us a very nice set of slides that are in draft currently, and the document is in draft, but I've missed how you're going to finalize it and what do we do with that document. So we need that, right, from the coalition. And then finally, I'd like to thank the organizers for bringing us together. It's been excellent. And I think Michelle is right. This should have been in the main plenary. But I think it was good that it was here, that we could have a more intimate discussion. So thank you very much, Chair.
Thank you so much, Professor Pillay. And I think once again, the point that is coming through is really on the importance of meeting, and which is what Ndugu did at the beginning, meeting us at our point of care as holistic people, and using each contact to prevent disease progression, not just for HIV, for other diseases. I think we've got the Botswana model to learn from. What is their name called again, Lebu? They are called NAP. Health promotion. Yes, but the Botswana model has. Yes, so they've gone beyond just HIV and TB. They essentially go into health promotion as a whole. Let me then first acknowledge our participants, I think online as well as in the room. Thank you so much. I'd like to thank our presenters. I'd like to thank our panelists. Your insights really brought a lot of vision and guidance into the future of prevention. I also want to thank our rapporteurs. I think, as Jürgen was saying, you could tell where the tensions were coming from, but you can tell also what issues we need to address with the little resources that we have. This event could not have come at a better time when you look at where we are in terms of where the world is moving globally around funding, but also related to the pressures related to prevention. I think the conversation has reaffirmed the need for stronger, more resilient and truly country-owned responses. We've heard consistently that countries need to drive where they are going. And I think this could have not come at a more important time as well as we are planning for GC8. Now, as much as I was happy when Ndugu said Global Fund must be thanked for GC8, the replenishment, I would like to thank South Africa and the UK as AHA. Please clap for us. Thank you. So in closing, let me express my deep appreciation for everybody who is in the room. Your commitment, your expertise, your willingness to engage, to be frank, has really helped to shape the HIV prevention response moving forward. And I look forward to us engaging further with you as the HIV Leadership Forum. There's a paper that's just been put in front of me. Maybe, Margaret, you can just come and there is dinner. Okay, dinner starting now at the main restaurant on the 3rd floor, and it's on us. So good night. Thank you so much. Thank you. Thanks.